exclusion and inclusion criteria used in the CDK4/6 inhibitors have been rather uniform. There have been a few exceptions here and there, but for the most part, they called for hormone receptor positive breast cancer using CLIA guidelines. They used NCCN guidelines to define menopausal or premenopausal, depending on the trial. They included patients with bone-only disease if they had at least 2 lesions or one that was measurable, a lytic lesion. And they also required that patients had acceptable liver function tests. They could have some abnormalities in their transaminases, but there were some limitations in that area. They had to not have significant prolongation of the QTC interval to start with. And those were generally the eligibility criteria. There's many factors that we have to consider when treating patients with hormonal or hormonal embiotherapy. One of them is the tempo of the disease, and that can be measured in several ways. One way is what is the disease-free interval from when they completed or had their adjuvant therapy for early stage to when they recurred. There's a sense that there may be some relative resistance to hormonal therapy in patients who have recurred within 1 or 2 years of completing their adjuvant hormonal therapy, whereas patients who are de novo, who present with metastatic disease, seem to be more sensitive. Nevertheless, when one looks at the benefit of CDK4/6 inhibitors across these categories, they're roughly the same. It's about a doubling of the progression-free survival. Now, the absolute progression-free survival, true, may be shorter in someone who has completed their adjuvant hormonal therapy more recently compared to someone who is de novo, but the benefit is still the same, and we haven't yet identified a clear group of patients that don't benefit from the addition of CDK4/6 inhibitors to letrozole. I think that the kind of patient who might be a candidate for chemotherapy up front, very heavy visceral disease, rapidly progressing, highly symptomatic, then those patients would not have been eligible for these trials, and nor would we generally want to treat them with endocrine therapy anyway. I should also add that some of the rare situations that were excluded in these trials have to be taken into account. Patients with brain metastases were excluded, although I generally don't think that's really an exclusion for anything as long as they're treated and stable. And then patients with inflammatory breast cancer were excluded also. And one might argue that that's a more aggressive disease that should be treated with chemotherapy, but it's also a very disease that's hard to follow clinically, so judging responses would have been difficult on the trial. But I think in carefully selected patients of either of those categories, one could use endocrine or endocrine biotherapy. Now, the second part of this issue is who might be a candidate for endocrine therapy only, and none of us really can identify who that patient might be. We just haven't come across factors. There has been some recent description of certain factors like loss of retinoblastoma, which may occur on treatment, or at baseline high cyclin E levels, which might be an escape through CDK2. But we need a little more validation of those to see if those might influence our decisions. The primary and secondary resistant mechanisms of CDK action are still elusive. Initially, there was an attempt to look at retinoblastoma status, which is uncommon in hormone receptor positive cancers. 80 to 90% have intact RB, but the presence, for example, of cyclin D amplification, which is also seen in maybe a third of these patients, didn't seem to have an impact. But recently, as we've gotten more data from these trials and started to more comprehensively analyze both baseline tissue and also some very elegant studies where they were looking at multiple samplings along the way while patients were on treatment using liquid biopsies, using blood-based, we have learned a little bit about some potential mechanisms. One of these is the loss of the retinoblastoma protein, which may be there at the beginning, but on serial blood draws, when you look at the retinoblastoma gene in the liquid biopsies, that some patients do lose this. Another interesting feature that has come up is amplification of the fibroblast growth factor receptor, FGFR. And these seem to also serially come up, and there are actually some strategies now to target FGFR. However, it is too early for us to know what is the relative risk, and so we're not quite ready to use these in the clinic. But I think as time goes on and as we validate these changes, that we will be able to use them in the clinic, especially as we more routinely start doing liquid and solid tumor biopsies. One other common mutation, the ESR1 mutation, that is the estrogen receptor alpha, seems to be associated with resistance to aromatase inhibitors. But interestingly, in the Paloma-3 study, when they looked at ESR mutations, it didn't seem to make a difference in prognosis or in the response to palbociclib added to fulvestrant. So while we think that's an interesting biomarker, we aren't really using that in decision making yet.